Good morning. It gives me great pleasure this morning to introduce to you Professor Alain Gilbert, Président d'honneur de l'Institut de la Main, the Hand Institute. Professor Gilbert did medical school, Faculté de Médecine Saint-Antoine, Paris, graduated in 1971, so most of you were not born by then. Interne des Hôpitaux de Paris, that's the equivalent of our residency here, that started in 1971, and then chef de clinique 1977, that's equivalent to our assistant professor here, and professor of orthopedic surgery in 1992. I saw on his CV Chevalier de la Légion d'honneur, and I had to look this up because I had no clue what it was, thanks to Google and Wikipedia. And it translates to Knight of the Legion of Honor, and based on Wikipedia, and I may be wrong, it's the highest French order of merit, both military and civil, established by Napoleon Bonaparte in 1802. And then he chaired the University Diploma of Hand Surgery in Saint-Antoine, University Diploma of Microsurgery. These are teaching diplomas, and then microsurgical laboratories in University of Paris. A lot of leadership position. I'll let you glimpse through those. In the French, president of the French Society of Hand Surgery and president of the European Congress of Hand Surgery. More than 150 publications. His main focus is brachial plexus injury, adults and children since 1977, of course, involving microsurgery, nerve surgery, and he also has interest in congenital malformations of the upper limb, and apparently currently practices in Spain, Barcelona, and when I think Barcelona, I think about this guy, Gaudi, a great Spanish architect and famous Sagrada Familia. But I also think about this guy from Barcelona. Alain, welcome to Madison. Bienvenue.
Thank you. Okay. I'm going to talk to you about a subject which I've been working on for the past 45 years, and that is the treatment of obstetrical paralysis. This is a kind of the last article that you see is a kind of a summary of the latest ideas that I have on this obstetrical palsy. Now, first, very quickly, we have to see, we have to have a right diagnosis, and because most of the diagnosis is done by just looking at the patient. And this is when you look at this patient, you know from the beginning that this will be an upper root paralysis. And when you look at this patient, you know it's a complete paralysis. And of course, to help us, we have a few other signs like the Horner sign. And Horner, as you can see, is supposed to be pathognomonic of paralysis. But in fact, there are cases which show, look at this patient with a severe Horner, and in fact, this patient has a normal hand. So you can have a Horner without paralysis, and you can have a complete paralysis like here without a Horner. So it is a good sign, but it's not pathognomonic. Now, just a little question about congenital brachial plexus. You may come up to this question someday because of low implications, and very often the gynecologist defend himself, saying that it's a congenital disease. In fact, as you can see, I have seen only 3 cases out of 6,000, so it's extremely rare. But it happens, and this is a patient where the brachial plexus is replaced by some fibrous tissue. Now, of course, the OBP is very often associated to fractures. Clavicular fracture is very common, and it's usually done by the obstetrician. And humeral fractures and also metaphyseal fractures, these are, they heal very well, and they heal very quickly, usually after 3 weeks. So if you have a doubt about the association, you just wait 3 weeks. If it stops, if the paralysis stops after 3 weeks, it was a pseudo paralysis, not a real paralysis. Then we have some more severe lesions like epiphysiolysis. This is rare, but it can give some, if it's not treated, it can give some problems with growth. And of course, the worst is the dislocation of the shoulder. And this is also very rare. As you can see, I've seen only 4 cases in 40 years, but it always needs a surgical repair. It cannot be treated like a dislocation in sport injuries. Now, to assess these patients, we have to assess the muscles and the movements, especially functions, because in these babies, it's very difficult to assess individual muscles. So what we try to assess is in the upper part of the plexus, the 3 important functions are the deltoid and abduction, external rotation, and biceps. And in fact, only the biceps can be really studied because the other muscles are a mixture of different functions, and it's very difficult to assess individually each of these muscles. In the hand, the 2 main functions to assess are wrist extension and finger flexions. So why do we need to study the biceps? Because it's a pure upper root. There is usually no no innervation coming from the lower root. So if you have a biceps paralysis, it is pure upper extremity. And how to study it? And that is very important to understand that it's not something easy always to study. It should be studied, as you can see, by touching the biceps. And at the movement, you must feel the contraction of the biceps, because it is important to remember that elbow flexion can be given very well by brachioradialis. So you can have a complete biceps paralysis with a good elbow flexion. And that's a completely different signification. So feeling the biceps is very important. Now, wrist extension is also important, not really to determine if the patient has to be or not, and we'll talk about wrist extension and the implication of C7, but also to determine the technique. And we will see that according to the fact that there is or there is no wrist extension, then we have a different indication. Of course, hand function is very important. It's easy if it's a complete paralysis, very difficult to assess if you have a partial paralysis. So evaluation of this extent is very important, because we need to decide if the patient needs an exploration and the timing, because we need to prepare the child and the family. We have to tell the family before that we will need clavicular osteotomy or contralateral C7 transfer. Where are we going to harvest the graft? And this has to be done, to be said, before the operation, of course. So that is why a partial hand impairment is difficult, makes the evaluation of the extent difficult. And then there is a problem of C7. You have always heard that wrist extension means wrist and finger extension means C7, but in fact this is a slide from Borrero, and look at this patient. He has a good C7, but there is no wrist extension at 3.5 months. On the contrary, this patient has a normal wrist extension, and he has an avulsion injury of C7. So it is very difficult to say that C7 is involved or not, just based on examination. And then we come to this evaluation and examination, which is difficult in a child. Of course, most people use the Mallet shoulder score, which is very interesting to follow the post-op and to have in older children, but it's totally impossible in babies. Then most of our indications are based on this study that we did with Tassin in 1977, when we look at the evolution of the patients, non-treated patients. And we saw that if the biceps was recovering before 1 month, then the shoulder would have an almost perfect result. If it recovered between 1 and 3 months, the grade 4 shoulder was obtained, which is a good enough and usually does not need operation. And if it was not recovered after 3 months, then most of the time it would need an operation. That in complete paralysis, the problem is a little different because our aim is to recover the hand. So we don't care if the shoulder or the elbow recovers. The problem is that we need to operate a patient who doesn't have recovery of the hand. And that is difficult if you wait, because after 5-6 months, in most patients, they will have some kind of recovery of elbow and shoulder. And then the family will think, and even many doctors will think, that it is starting recovery. And then we have to wait. And this is a big mistake. Now, we have still now 2 main controversies. Should it be operated? There are still people who feel that obstetrical paralysis can recover better if not operated. And we see that even in papers now. It's not very scientific because the problem comes also from the specialty of the people who assess it. Because I remember I had a long discussion with a very famous Swiss neurologist called Mumenthaler, and for him, a patient who could use his hand was an excellent result, even if he had no shoulder. So we're not talking about the same thing. So in all my experience, I have used the biceps recovery as a marker for deciding about operation. But there are some others, and especially in the US, quite a lot of people use the Toronto scale, which is a bit more complex, but has, for me, a big problem is that it doesn't take into account biceps recovery. It speaks of elbow flexion. And when, as I told you, when you speak of elbow flexion, you're not talking about biceps, you're talking about brachioradialis, and that's not the same roots. So that's why I am not very happy with using this type of scale. Now, there have been several publications since 40 years. You can see the list, which have showed approximately the same result. And that's there was an excellent paper which was made by Tondag from Holland about this series, and he published this review of all the publications, and he was very much in favor of surgery because of a lack of recovery in spontaneous recovery. So then the second discussion is about the timing. For most surgeons, it is 3 months. But quite a few people use 6-9 months. And that's also due to the fact that it's sometimes difficult to schedule a patient very quickly in a hospital, and they have to wait. And for some others, they depend on the assessment scale. The question is it better to do it at 3 months or at 6 months? There is, in fact, no difference. And I don't think the result will be different if you operate early or not. But what happens is that if you do the surgery later, then there will be, it's probably more precise, but you will have another problem, which is that the families will see a little improvement, and then many of them will escape surgery. That's why I think that our choice between an early operation with the risk of an excessive indication or a late decision that will induce some refusal. And we prefer that to do the early surgery, as we know that early surgery gives excellent result. Now, these are finally the indications. Upper palsy, no biceps at 3 months, and we will see in details, and complete palsy, Horner syndrome, no hand function at 3 months. This was, you see, almost more than 40 years of experience. Just a little thing about size, and just to remind you that there are a few patients, not many, which have bilateral cases. And these bilateral cases are always related to breech presentations, or sometimes I still have two with operative delivery. Now, in pre-op, what should we do? EMG, it may be interesting sometimes for precise diagnosis, especially to see if there is absolutely nothing that would mean more of an avulsion, but not for prognosis. The neurologists that think that they can be based on the EMG, they make mistakes. Now, CT, MRI, for many years, I thought they were not necessary. And in fact, I did a lot of myelograms, and you see quite a lot of false positive and false negatives. And the problem is like the myeloscan, they're much better, but it's invasive, and it's difficult to do this exam and then do immediately after surgery. The anesthesiologists are not always happy with this. And MRI is, of course, better because it's not invasive, and it can give much better images now, and we can really use it, and it's very interesting to use MRI. And that's why now I use MRI when I can, and I will tell you why. So now the second, we come to the operation, and of course there is the problem of intraoperative decisions. It's not only the decision to do the operation, is what will you do during the operation. And it's not always easy because that's where you need a lot of experience. You can be based for the indication on MRI and a lot of examination, but for this you need to have experience in surgery. So let's talk the different aspects. Talk about the different aspects. The flail, shoulder, and elbow, which will mean usually avulsion of upper roots, and this we will need nerve transfers, and nerve transfers for elbow flexion and nerve transfers for shoulder and external rotation. For elbow, double nerve transfer. That's what I do in avulsion. I do 2 nerve transfers for when there is an avulsion. If it is done for a rupture, I will do only 1. For shoulder abduction, of course, we all do suprascapular to spinal accessory to suprascapular. This is the classical thing. And the question is, should we add axillary nerve transfer systematically? I believe now that we should do. This is the type of result. This is a patient after 7 years. Now, these are the discussions. Why should we do a double nerve transfer? It's because what we have seen is that if there is a neuroma, there is, in fact, a good possibility that there is a partial renovation of the biceps. And in those cases, if you do only 1 nerve transfer, you keep the possibility of having a part of the biceps recovery through the neuroma. This we avoid the risk of failure. If you have an avulsion, there is absolutely no chance. Then you will do a double transfer. About the deltoid, in fact, I thought for many years that it was enough to do suprascapular reconstruction, but those patients, when you start seeing them at 8 or 10 years, they lose sometimes some of their abduction because the arm becomes heavy and they don't have deltoid. And so I think that in these patients, again, we should do also a transfer for the deltoid. Now, if it is a rupture, if it is not an avulsion, and if there is no wrist extension, you understand, complete paralysis, C5, C6, and maybe C7, then I will always use grafts, much better than nerve transfers. And one of the problems is the wrist extension, because if you do nerve transfers, you may get a good result in the proximal part, but the problem of the wrist is not solved completely. I'm not saying it's impossible, but I still wish to see long-term results before I will do that. So this is a patient with graft. You see that all these patients, even with excellent results, they have a very slight shortening. So why do we choose grafts? We choose graft because when it works, a graft is better than anything, because you don't treat specific muscles, but you treat all arm or part of an arm, and we can then use secondary tendon transfers. If you have an upper root rupture with wrist extension, and that's what we said before, then we can use triple nerve transfer. And we're not in emergency. You can wait. You don't have to do it at 2 months. You can do it 1 or 2 months later. Now, for upper palsy, the question is graft or nerve transfers. Isolated nerve transfer give excellent result. When a graft is good, the result is close to perfect. Then why, that's one question, is why association of graft and nerve transfer decrease the result, and we will see these things. For instance, when these are patients, it was a series of 100 patients who had nerve transfers, and when we look at them, you see that in the complete lesions are not so good. That means that why aren't they good? Because we are treating the same shoulder, but they are associated to a lot of grafts, as the upper lesions are usually treated by only nerve transfers. In complete paralysis, of course, exploration is fundamental, because we have, what shall we do? And of course, this is the classical thing. If we have 3 upper roots, then we can repair the whole plexus. But in 2 roots, what should we do? Should we try to repair everything? Should we try to repair part of the plexus? Should we associate with nerve transfers? And this is where the quality of the roots are very important. And that is why we need to develop studies of the quality of the roots. And we're using EMG, intraoperative electric studies. We are using staining, but at the moment it's a little difficult to assess. If we have only 1 root left with 4 avulsions, this was what was the idea before, I would say 20 years ago. Now I would go directly for contralateral C7. And there is an indication for primary contralateral C7 if there is 4 or 5 root avulsions. 5 root avulsions are extremely rare. I think I can count them on the fingers of one hand in 40 years. So mostly 4 roots avulsed. This is, for instance, a patient who had 1 root avulsed and 4 avulsions. We used the contralateral C7 with allograft. How late can we repair the plexus? We know that we don't have good results if we operate after 12, 18 months. We can do it later, but the results will be very partial. And nerve transfers are possible, of course. This is a patient, for instance, 9 years old. This patient had no elbow flexion, and I did a long graft to the biceps, and you see that he recovered biceps function. This was published in 2013. We operated with Raimondi. We reviewed 52 patients with late nerve transfers. And especially this is late nerve transfers to the elbow flexors. And you see that most of them are over M3 and they have good results. So it is possible to do late transfer. In suprascapular reconstruction, not so good, but still we can have good results. And then we can see that in biceps reconstruction, it can be done very late, as in suprascapular reconstruction, it's 50-50. This is a patient done at 18 months to 6 years. She was operated at the age of 2 years by nerve transfers. And when we look at the results according to the timing of these late transfers, you can see that even after 2 years, we still have a majority of good results. Now, when these patients come very late, we have a problem. If we still have fibrillation, it is possible to still do nerve surgery. And we will do nerve transfers in the upper roots, and contralateral C7 for lower trunk. And these patients can be operated at 18 months, 2 years. This is the contralateral C7 using the Wang technique. This is the type of cases. You see this patient, for instance, is 2 years, and he has a reasonable elbow, but absolutely zero in the hand. So in these cases, when I do contralateral C7, I will use always allograft, and I will tell you why, for two reasons. One is that this is the good indication of the allograft when you have a normal nerve on the other side. And the second thing is that passing grafts like we used to do behind the esophagus is a little dangerous in small babies. I have done 42 repairs with allografts. See average age. See quite a lot of contralateral C7. There were 3 failures, and they are very interesting. They are probably more interesting, the failures, than the successes, because you see that one of them was a disruption of distal suture, and 3 of them were poor quality of proximal roots. And that's why I think now that it is very important to assess the quality of the root by pre-op MRI and all types of examination that we can do during the operation. So that is something that we have learned with that. So from this experience, and I have done cases with upper root, complete paralysis, total avulsion, what I found is that in the repair, the allograft will give similar result, but the recovery is slower, sometimes 1 year slower. The results are clearly determined by the quality of the donor root. And when we have a poor quality root, where the autograft may accommodate, the allograft will not, and it will be a failure. But when we use an excellent root, like contralateral C7, the allograft will give us results which we cannot get with autografts. See, at 1 year, absolutely nothing from the contralateral C7. And we are at 2 years, very, very little. And at 2 years, so it takes, we need to be patient, for all this. And again, 11 months. And of course, this idea of reconstructing systematically the hand, not like in adult, was confirmed by many authors. And you see a recent paper from Toronto, where they totally agree with reconstruction of the lower roots. Now, after 45 years, the conclusion is that in severe OBP, the treatment must be surgical. The initial assessment must be perfect. And the nerve transfers are useful, but cannot be the unique treatment proposition. And there are still many situations where the graft is the best solution. Delayed nerve transfer can give good results, and in severe multiple avulsions, contralateral C7 may be used. I just want to, for those who are interested, to say that we are going to talk all these subjects in this meeting in November. This will be presential meetings, not by video, we hope. And next year we'll talk on lumbosacral repair of the plexus. Thank you.
This was amazing, Alain. Thank you very much. Great overview. I probably my first question is about the contralateral C7. How happy you were with the results, and also the experience with allograft is also unique here, because I see you're using like 8-centimeter allograft. So if you can comment a little more, and do you use total C7 or partial C7?
Sorry, can you say again the last part? Last sentence?
Do you take the entire C7 or just partial?
Yes, entire C7. Or each time I've used partial C7, it was a failure.
So we have colleagues here from plastic surgery, colleagues from Michigan. So you can just unmute yourself and use this time to ask Alain questions.
Alain, this is Neil Salyohung. I'm one of Dr. Hanna's colleagues from plastic surgery.
Yes.
That wonderful talk and amazing results over a great time and number of patients. I'm curious about the allograft use, and I know that Amgad asked this as well, sort of, but we are constantly being pushed by the manufacturers, of course, to use more allograft. But given your excellent results with the cross C7, very long grafts, these 7-centimeter grafts, have you gone over then to your primary rupture repairs of using allograft instead of autograft as well?
Yeah, you mean on the affected side?
Yes.
Yes. Yes, I have done all this. When I done this series of 42, they were maybe 2/3 were on the one side without contralateral, and as I said, the results first they were a little disappointing compared to the autograft, and now after 4 or 5 years they become at the same level. That means they took much longer time, sometimes 2 years more than an autograft, but it came finally. So there is, in my sense, there is no indication to use it as a in primary surgery, like repairing C5, C6, if you have autograft. Of course, if you do not have, if it's a secondary repair, you have a lot of indications, but not the primary thing. On the contrary, using it for contralateral nerve is excellent. And as I said, because also you have a long graft, which you do not have this, it's very difficult to pass in the neck, these autografts. And it can move, and you can lose the graft, and it's a little very difficult. And so with the autograft, we get, and also it's exactly the good size for the C7. So it's for me, it's really the best indication is the contralateral. In fact, it's getting to a normal nerve. That's why in the peripheral nerves, the results are good, because if you cut up to a normal nerve, then you will have an excellent passage of the axons. The problem in the brachial plexus is the roots are very often not very good.
And in terms of size, what would be the longest you would do for allograft? The longest you would use?
The longest?
Yeah.
Well, they don't have more than 7 centimeters.
Yeah, I know some people cheat and sew two together.
I understand. You mean put two together? No. In a baby, you don't need that. And you know, in an adult, you don't need an allograft because in an adult you can do direct suture. But in babies, it's impossible. You cannot do a direct suture with C7 in a baby. But in an adult, you can do it.
Alain, this is Benny Iskandar. I'm one of the pediatric neurosurgeons here. I have two quick questions. One, do you ever do end-to-side anastomosis? And second, I'm interested in your comment about MRI because, as you know, in babies, we have to sedate them to get MRIs. How does that change your management?
Okay, about end-to-side. I published this with Pondag about, I think, 12 years ago, a series of patients with end-to-side. And what we found is that it could give a good result, but it was absolutely not predictable. And about 50% of patients got poor results. So, if you have nothing else, then you can use end-to-side, but you can absolutely not use it as a standard repair. Now, for you were talking about the second question.
The MRI.
MRI. Well, I must say, I have for more than 30 years when I give lessons and conferences, I always say, well, MRI is not necessary and you can avoid it. And I don't think so because I find that now after long experience and many cases, I'm still unable to, just by looking at it, saying if a route is excellent or not. You always make mistakes. And I think that all the bad results we have are coming essentially from lack of assessment of the route.
Do you ever use nerve action potentials intraoperatively to assess how bad the neuroma is?
I cannot hear you.
I'm sorry, I'm on vacation and it's windy here. Sorry about this. But
me too.
So, do you ever use nerve action potentials to assess neuroma
Yes.
function intraoperatively?
Yes, it's not action potential through the neuroma. It's action potential with brain. You try to think if to evaluate the quality of the nerve by stimulating the nerve and recording in the brain. So
somatosensory, probably.
Yes, exactly. Yeah. It's not through the neuroma. The neuroma, for me, I have always thought that a neuroma has to be cut. There's no neuroma that you leave. If you leave it, that means you should not have operated.
I see. So you're really just
Neurolysis is not an operation.
I see.
In brachial plexus.
So you're just checking the integrity of the proximal segment to see that there's communication with the brain.
Exactly. Yeah, absolutely. But it's still not completely reliable. But I think it's a way. And also chemical studies will also be probably useful, but it needs to be quick. That is a problem.
Any questions from Michigan, Dr. Yang and her team? I know they're probably operating as well. Okay, if there are no other questions, we'll let people go to the OR. Alain, thank you very, very much for this amazing overview.
Thank you.
And see you again.
Okay. Thank you very much.